Hello and welcome, everyone. We're so glad you could join us for today's ACO Certification Application Requirements Overview webinar. My name is Mike Stanek. I'm an Associate Director on the HBC's Healthcare Transformation and Innovation team. I'm joined by my colleague, Christy Helsel, a Senior Associate on the team, who will be working closely with all of you this year. Also participating in today's webinar is Catherine Harrison, the Deputy Director of the Healthcare Transformation and Innovation team, and one of the architects and long-term supporters of the certification program. I want to kick us off with a few housekeeping items. First, we're going to keep all the lines muted today. Please submit any questions about the webinar content or the platform user guide as they occur to you by entering them in the Q&A box. We'll answer them as we go as appropriate, but we're also going to try to leave some time at the end to get to as many additional questions as we can. And then we'll also note those that we cannot get to today, and we'll follow up as appropriate. We are recording this webinar. Both the recording and the slides will be available on the ACO Certification Program website after the event. And I'll take this opportunity to plug our office hours series, which will be on Wednesdays at 11 a.m. throughout the summer, starting on July 12th. As we have in prior years, we'll open up a Zoom line once a week where folks can drop in and ask questions about the ACO certification program, the application requirements, or the process. These are completely optional, but they're a great chance to not only ask your own questions, but hear what questions folks from other ACOs have about the program or the application process. So keep an eye out for a calendar invitation for that series in the near future. And Christy and I are always available offline to talk one-on-one about aspects of your application. Please don't hesitate to drop us an email. So there'll be plenty of opportunities to get all of your questions answered. Next slide, Christy. So before we dive into our main topic today, we did want to take a few moments to refresh folks on the basics of the HBC's ACO certification program. ACO certification is written into the landmark 2012 state cost containment law that created the Health Policy Commission. Given the proliferation of risk contracts and ACO programs over the past decade or so, the certification program exists to create a set of multi-payer standards. That is to say, standards not tied to any particular payer, contract, or market segment, as a means of enabling care delivery transformation. To that end, we do strive to make sure that our standards align with and complement other requirements that exist in the market as much as possible. Another important goal of the program is to advance knowledge and transparency about ACOs in the Commonwealth. To that end, we've produced materials like short profiles of each ACO and high-level summaries, recently released, of ACO strategies to transform care delivery. In that vein, we're also interested in exploring ways to facilitate learning across the healthcare delivery system. As a historical note, the ACO certification program kicked off in 2017 with the program's first 2-year certifications awarded at the end of that year, and we're now kicking off our 4th application cycle. 2 years ago, we made our first substantive changes to the certification criteria, refocusing them on ensuring ACOs are positioned to learn from and iterate on their activities over time. Under what we call the Learning Equity and Patient-Centeredness, or LEAP standards, we built on our tradition of recognizing core competencies of ACOs to embrace the ACO model as a catalyst for learning and improvement among healthcare organizations. Finally, in the insert here, you can see a few key program stats. As of this year, there are 17 certified ACOs in the Commonwealth, representing nearly 100 risk contracts and more than 3 million covered lives, roughly evenly split between commercial and public risk business. Now I'm going to turn it over to Christy to provide a refresher on the LEAP certification standards.
Thanks, Mike. And thanks everyone for joining today. I'll start with just giving us a brief overview of the agenda and the plan for today. As Mike mentioned, we'll start with reviewing the application criteria for certification, and the components that this includes are the definition of what it means to be an applicant for certification, prerequisites to apply, the assessment criteria, and this year's supplemental information questions. Once we've spent some time reviewing the application criteria, I'll turn it over to Mike to walk us through the updated health equity requirement. Then we'll end with an overview of this year's application process and timeline, and I'll open up the virtual floor to answer any questions that you might have. With that, we also ask that as we're going through material during the presentation today, if you do have any specific questions, feel free to pop them in the Q&A box, and we'll aim to answer them during our session today. and spend some time, as I mentioned, at the end. So starting with the definition of the applicant for certification. I'll start off with saying that this definition will remain the same this year as it has since the launch of our program. So for the purposes of application here, the applicant must be the healthcare provider or provider organization that has partial or complete common ownership or control of any and all corporately affiliated contracting entities that enter into risk contracts on behalf of one or more providers. In other words, the entity within a health system or provider organization that has common control over all entities holding a Medicare, a Mass Health, or commercial payer risk contracts is the one that would be recognized as the applicant. And then each component ACO and the applicant itself, if it does hold any risk contracts, must meet all certification requirements within the context of the program. So we'll walk through this and point out areas where it's especially important to note. But we did want to note that as you're working on the application, to remember that this application for certification, it represents that set structure, and it'll be determined on kind of what is included within your application, and represents the activities from the past 2 years. So it'll include all the component ACOs within your organizational structure within that time frame. And so if that applicant, or in this example we have here, the ABC ACO, if the applicant does not satisfy the certification criteria inclusive of the component ACOs, then each component ACO needs to individually demonstrate meeting each of the specific requirements. In terms of the application itself, there are 3 main requirements, including 3 prerequisites, 5 assessment criteria, the health equity requirement, and supplemental information questions. These requirements, if you have submitted the application with us in 2021, these requirements remain largely the same as the 2021 application cycle, apart from the health equity requirement and the supplemental information questions, which we'll dive into more detail at the end of the hour. But before we head there, I did want to note that, as Mike mentioned before, we refer to the certification requirements as the LEAP standards, which really aim to encourage ACOs to pursue evidence-based and data-driven strategies to improve care delivery. You'll notice a theme throughout the application, especially as I review the assessment criteria, where we ask ACOs to both describe the information or data that they're collecting, and then how they're actually using that information to advance the goals in the learning, equity, and patient-centeredness standards. So to start us off with the prerequisites, there are several prerequisites that the applicant needs to meet by providing information on ACO governance, on risk contract structures, and quality performance, as well as attesting to a series of legal and regulatory expectations for organizations applying for certification. On the right-hand side of this slide, we have that series of legal and regulatory attestations listed here. I won't walk through all of them, but do want to note that this includes attesting that the applicant, inclusive of those component ACOs that I mentioned before, has complied with each of the statements listed here. On the left-hand side of the slide, you'll see the uploads that are required in the application in the prerequisite section. So first, applicants will need to upload an organizational chart of the ACO's governance structure. This includes an identifiable and unique governing body, any executive committees, and demonstration of how each of those bodies are managed within the ACO. So if your organization has component ACOs, you will need to provide a separate organizational chart for each ACO governing body. The second piece here is that applicants will need to upload a risk contracts template that we will provide, and remains, again, largely the same as the previous application cycle. However, within this risk contracts template, we are now specifically requesting that any health equity incentives in a contract be included in the description of contractual quality incentives provided in the template. And just as a general reminder, this template includes details on the payer, across risk contracts, the number of covered lives, financial terms, the description of quality incentives, and now, as I mentioned, that a description of health equity incentives as a component of quality. Lastly, applicants are asked to upload a final ACO level quality performance on all measures included in risk contracts for the most recent performance year. We don't have a template that we provide, so we do just ask that you upload the most recent summary report of that information available. Before we dive into the assessment criteria, I do first want to take a few minutes to review the different types of documentation that ACOs can provide to adhere to the standards. So within each section of the application, we specify what our expectations are for meeting each of the standards. And in most places, we will ask for a primary source document or an original narrative. And in other places, we will give you a template to complete and upload into the application portal. So with that framing, the first type of documentation are primary source documents. These are materials created within your organization within the past 2 years leading up to the certification period. And this could be an internal memo, a summary report, presentation, or a screenshot from a tool that's being used by teams, among other materials that you would have generated within your organization. Our hope here with primary source documents is that they really help to streamline the process, the application process for ACOs, and where possible, avoid requiring ACOs to create net new material for the application. So if you have ready-made documents that demonstrate adherence to the standards, we encourage you to submit those, and we're happy to work with you on determining whether the materials that you have will satisfy certain requirements. When a primary source document is not available, the second type of documentation is the original narrative, which is a written description of how the ACO meets an assessment criterion. And you have the option to upload these either as a Word document or a PDF when you don't have a primary source document that's readily available. And I'll note here with the original narratives that we do have more information as to what is specifically required of those narrative responses in our platform user guide or PUG that we had distributed before this meeting. And then finally, the third type of documentation are the Excel templates that we'll provide to you in different areas and ask you to complete and upload. I'll also note one other thing here just about confidentiality, and we'll get into this later in the webinar. But I will pause here just to remind folks that in general, information that is submitted as part of the ACO certification process is held confidential. And we'll talk a little bit more about this near the end of the webinar. So with that, now that we've reviewed the types of documentation that applicants can provide, I'll walk us through each of the assessment criteria in the application. Beginning with the first assessment criterion here, our patient-centered care standard. What we're really looking for in this standard is to better understand how ACOs are collecting and using information from patients to deliver and improve upon patient care. There are two parts of the standard, and they're directly related and really build upon each other. The first half of the standard that the ACO is monitoring and assessing patient experiences, perspectives, and preferences across the patient population served is connected to the second half of this standard, where we ask ACOs about how the ACO is using the information gathered to really inform strategy and organizational level initiatives to improve overall patient experience. In terms of actually meeting this requirement, we ask ACOs to provide both a description of the approach for gathering the information from patients, including a sense of scope and scale and how frequently the information is collected. And we also ask for a description of how the need or the opportunity for initiative is being identified from the information collected, including how this initiative is being measured to assess its impact on the desired outcome. In a few slides on this criterion in particular, I'll go into a deeper dive and actually walk through kind of the specific approaches that we're looking for here. But I will say for all criteria, including this one, we do provide considerably more guidance in the PUG document in terms of meeting the standard. Moving on to the second assessment criterion, this standard aims to understand how ACOs are really fostering a culture of continuous improvement, of innovation, and learning to improve patient experience and the value of care delivery. We ask ACOs to demonstrate this through at least two approaches in the application, whether it's periodically convening leaders in the ACO to discuss performance improvement goals, it's setting up internal financial incentives, or establishing processes or systems for reviewing performance. These are just a few of the different approaches that we outline in the application and further describe in the PUG. But in responding to this criterion, we ask ACOs to provide an explanation of how each approach really contributes to a culture of improvement in their ACO or ACOs. In the third assessment criterion, data-driven decision-making and care delivery, we look to gain a better understanding of how ACOs are using data available to guide and support improved clinical decision-making. This criterion, like AC1, is divided into two categories. The first, we ask ACOs to describe the processes or tools they use to make current and reliable clinical knowledge available at the point of care. So this could be through activities such as launching an initiative that's geared at reducing inefficiency or waste in the system, or practice provider variation. It could be through encouraging use of clinical decision support tools, or really other strategies that make evidence-based protocols or learning opportunities available to providers within the ACO. So that's the first part of this criterion. The second part of this criterion, we ask ACOs to demonstrate how they are collecting and offering providers actionable data with the purposes of guiding clinical decision-making, reducing waste, and enabling high-value care delivery. There are two approaches that we outline in the application, and ACOs can do this through one of two ways, either by periodically sharing benchmark cost or quality performance information with providers, either at the individual or the group level, or by offering providers information on their patients at the population level. For example, in the cases of a case management report, as an example, identifying patients who are due for mammograms or diabetic patients who are in need of HbA1c tests. For both parts of this criterion, we do have certain requirements for what needs to be included in either the primary source document or the original narrative, the types of documentation I mentioned before. But one thing I will note is that if you are uploading a primary source document, we ask that you make sure that the reports, the memos, or screenshots that you're uploading into the application portal are de-identified, especially if it's representing patient data. Moving on here, the fourth assessment criterion focuses on how ACOs develop, implement, and refine population health management programs and other care delivery innovations to really improve care coordination, to better manage health conditions, and to improve the health of its overall patient population. Like AC3, this criterion is split into two parts, where in the first part, we ask ACOs to describe their approach in the form of a primary source document or an original narrative for collecting and using data to stratify its patient population, ultimately for the inclusion in population health management programs. So then, to meet the second half of this standard, we ask ACOs to complete a population health management programs and targets template, where we specifically ask ACOs to report on their suite of programs, including the specific interventions, target patient populations, the number of patients served, and information on metrics and targets for measuring the impact of these programs over time. And lastly, among the assessment criteria, our fifth assessment criterion really centers on whole person care, which is inclusive of integrating behavioral health care into primary care settings or behavioral health integration, and on addressing patients' unmet health-related social needs. For AC5 for the first part of this assessment criteria, we ask ACOs to upload a behavioral health integration progress and targets template. And this includes information including key priority areas, goals within each priority area across BHI, and current performance indicators within each of those areas. Another plug for the PUG here. We include a handful of examples regarding the behavioral health integration priority areas, but a few examples of this may include activities like supporting the co-location of behavioral health providers into primary care settings, incorporating behavioral health providers onto care teams, or implementing behavioral health screening and referral practices in primary care. So that is all of what is encompassed within the first half of this criterion. Then in the second half, AC 5.2, we ask ACOs to upload a primary source document or an original narrative that documents their health-related social needs screening and referral processes, parametrics tracks, and performance targets. On this one in particular, we have quite a few directions in the PUG that indicate what we're looking for in terms of a response on the second half of this criterion. To begin to put this all into context, this slide shows what the first assessment criterion on patient-centered care looks like in the application portal. I won't walk through all of the assessment criterion and what it looks like in the portal, but did want to share this one as an example and point you again to the PUG to see kind of what it looks like for the other assessment criterion. So if you have had a chance to glance through the PUG document, you'll notice that the language here is very similar to what we have in that document. There is, however, quite a lot more instructive information in the PUG, so it is worth keeping that document handy while you're working on the application. With that, I'll walk you through how you would go about completing the assessment criterion 1 section of the application. So first, you would select the approach or the approaches that correspond to the activities of ACOs you're documenting in the application. And if one approach here applies to both the applicant ACO and the component ACOs in your application, that's all you need to select here in terms of meeting the standard. However, if there are different approaches happening across ACOs, for example, one ACO is taking the approach of regularly monitoring patient experiences or preferences, while another is leveraging systematic data collection on patients' cultural, linguistic literacy, and similar care-related needs and preferences, then you'll need to select both to cover the approaches happening across component ACOs and also upload documentation that supports that. So as you're thinking through those approaches and selecting either a checkbox or checkboxes that reflect the approaches being taken to, in the first half here, monitor and assess patient experiences, you'll need to think about kind of what documentation you're going to provide to support the approaches identified. So as I mentioned before, for this assessment criterion, it's either a primary source document or an original narrative. And as I mentioned, if you select more than one approach because your component ACOs are taking different approaches to meeting the standard, then you will need to upload separate documentation for each component ACO. Lastly, for any primary source documents that you do upload, we ask that you provide a short description of the document in the text box that we have within the application. And if you do have different documents for different component ACOs, we do ask that you provide a short description of each within the text box. These descriptions, they really help give us context as to what the document is, and which component ACO or ACOs it applies to, and any other detail that we need to review the response. Specifically within the PUG document that we shared, in Appendix 2 of that document, we've also drafted example responses for these text box descriptions, not just for assessment criterion 1, but for all of the assessment criteria in the application. Our hope is that those examples help give applicants a better idea of what we're looking for in terms of structuring those responses. And we'll make a plug here to use that as a resource as you're working through your application. Moving into the third section that I mentioned before, the supplemental information section. So following completion of assessment criteria in the application, we have the required supplemental information section. This is typically the section of the application where we're interested in learning more from organizations on how they're thinking about certain ACO-related topics. In past cycles, we have asked ACOs about how they're facilitating the delivery of high-value care, and this upcoming cycle really continues upon that theme here in this domain. So this year, under the high-value care domain, we have 3 questions, including a short narrative response that's shown at the top of this slide, where we ask ACOs to reflect on the most important innovation or change to care delivery that they've accomplished that would not have otherwise been possible under a purely fee-for-service model. Then we have 2 checkbox questions where we ask for a few clarifying sentences for each checkbox that's selected. So they're not purely checkbox questions. There's a little bit of writing as well. And in the first on the left here, shown on the left-hand side, we ask ACOs to think about which performance targets have been the most difficult for them to achieve and why. And on the right-hand side here, we ask ACOs to describe the strategies that they are pursuing to deliver high-value care. For both, I'll review more supplemental information questions on the next slide, but I do want to note that for all of the supplemental information questions, we are looking for responses that best describe the overall characteristics or approaches that are being taken across the applicant and all its component ACOs. So here, unlike areas in other parts of the application, unless it makes sense, you do not need to summarize activities at the component ACO. For example, but this might be relevant for your ACO if, for example, you have a mass health contract and where a performance target and barriers to meeting that performance target are specifically apparent in quality versus a Medicare contract where the picture might be a little bit different and the focus is more on cost or cost trend. So it might make sense to break it down by the component ACO level if that's pertinent for your organization, but we do not require that for these supplemental information questions. We do, however, require complete responses in order to meet certification requirements. The last thing I'll note is when you get to the application portal, you'll notice that you have the opportunity to upload documentation in this section as well, and that's optional, and that's available to you in case it is helpful to support the responses that you share here within supplemental information. But we don't require uploading documentation to support this section specifically, to support the supplemental information questions. The other domain that we'll cover within this year's application in the required supplemental information section is Medicare Advantage. And we recognize that this might not be a relevant topic for all organizations if you don't have a Medicare Advantage or senior care options risk contract in place from the past 2 years. These contracts have historically not been a part of ACO certification. However, in recognition of the rising prevalence of Medicare Advantage and senior care options risk contracts in the Massachusetts healthcare market, we are interested in better understanding if and how these contracts fit into your ACO strategy. So we have 2 checkbox questions here for you. The first asking you to indicate how performance under the ACO's Medicare Advantage and or senior care options risk contracts is managed relative to other risk contracts held with the ACO. And the second on the right is asking you to identify which of the standards in the application also apply to the Medicare Advantage and or senior care risk populations. So with that, I will turn it back over to Mike to review the updated health equity requirement.
Thanks, Christy. Can you go to the next slide? Great. So just want to reiterate that all the assessment criteria that Christy just walked through are the same as in the last application 2 years ago. The health equity component of the application is where things will look new this year. Those of you who have been involved in the HBC's certification process before will recall that in 2021, we included a health equity component in the application for the first time. At that time, we asked ACOs to report on an initiative to address health inequity. And based on our review of those submissions, we shared a letter with each ACO last fall. That letter collected some of our observations and our reflections on future areas of opportunity for continuing to advance ACO's commitments to health equity. We focused in on 3 opportunities in particular: developing the processes and infrastructure that will allow ACOs to quickly translate improved socio-demographic data into concrete action, meaningfully engaging with patients to understand the communities and environments in which they live in order to develop programs responsive to their unique needs, and finally, bringing an equity perspective to ACO's current portfolio of population health management programs and setting explicit equity goals. That is to say, making strategic commitments to improving health equity. Those 3 opportunities form the core of our revamped approach to incorporating a health equity lens into certification this year. Next slide, please. As I mentioned earlier, one of our aims with certification is to complement existing local and national care transformation and payment reform efforts. So alignment with other developments in the market is very important to us. As I'm sure everyone is aware, health equity is now getting much needed attention from a wide range of stakeholders. Certainly that includes Mass Health, but also CMS and other payers, accreditation bodies, and other thought leaders on payment reform and healthcare delivery. We here at the HBC have closely examined the approaches those organizations have taken and the frameworks that they've laid out. And we've been pleased to observe that they align in important ways with the observations and the priorities that we had identified within the certification program. Many organizations and programs are emphasizing the importance of collecting socio-demographic data to identify inequities and target interventions to address them. That's true of CMS's new ACO REACH program and Mass Health ACO program, as well as expectations developed by the Joint Commission and the Healthcare Payment Learning and Action Network. Similarly, patient and community engagement are becoming recognized as essential elements to formulating strategies or interventions to promote health equity, as in NCQA's new Health Equity Accreditation Plus. And strategic commitments to health equity have been emphasized by organizations like the Institute for Healthcare Improvement, as well as in new requirements of the Mass Health ACO and Medicare's ACO REACH. Given these developments, it seemed clear to us that we have an opportunity to build on our prior equity requirement while aligning with a number of other organizations that are thinking about the responsibilities of healthcare organizations with respect to health equity. With that in mind, this year we are refocusing the certification program's health equity requirements on these 3 opportunity areas. This year, the application will require reporting on progress in advancing data-driven interventions, patient engagement, and strategy. Next slide, please. So what does that mean in practice? Well, ACOs will be asked to use a template that we provide to report on their progress with respect to 3 discrete activities, 1 from each of the 3 opportunity areas. Our hope is that this template will allow us to collect this information over multiple certification cycles in the coming years, so that we can take a more longitudinal approach to understanding ACO progress in key areas. Here you can see what that template for reporting this information actually looks like. Hopefully this isn't completely impossible for you to see. Each applicant will get an Excel template from us soon. We'll customize it, filling in the appropriate component ACO names as applicable. You can see that each component ACO will get a row for each of the 3 activities we're about to walk through. We'll ask you to characterize each component ACO's current status with respect to that activity by picking a status from a structured drop-down menu. And then there are 2 columns there in which we ask that you provide elaboration. In one column, we ask that ACOs provide an accompanying short narrative, explanation, or an example pointing more specifically to what they've been working on in the past year or 2. And in the other column, we ask ACOs to share some information about what commitments the component ACOs are making or what they expect to achieve in the next 2 years. Next slide, please. Now let's dig in on each of the 3 activities. The first activity ACOs will be asked to report on is on using various forms of socio-demographic data to monitor inequities and inform the development of interventions to address them. First, ACOs will characterize their current status on this activity using a structured dropdown. And you can see those structured response options here. These are meant to represent a continuum of progress. And we spell out in the PUG in a little more detail how we're thinking about each step in that progression. In brief, data collection only would mean a component ACO has adopted some standard for race, ethnicity, language, or disability, RELD, and/or sexual orientation, gender identity, and sex, SOGIS, data collection, has trained some staff on collecting that information, and is collecting self-reported data for a majority of its attributed patients or in a majority of ACO participating practices. So that status would represent systematically rolling out data collection on a material scale. Moving beyond that to inequities monitoring would entail meeting all of the data collection only milestones, while also beginning to stratify at least one metric at the ACO level using at least one RELD SOGIS variable, and then periodically reviewing that stratified metric with leadership and/or providers to identify health inequities. This inequities monitoring only status is where we've set the bar for our minimum standard this year. So we'd be looking to see that each component ACO is doing stratification of at least one metric by one variable. This is the only part of the health equity requirement where we've set a minimum expectation for this year. Moving on to the final two status options, these entail achievement of all prior milestones, as well as beginning to implement interventions or modifications to existing population health management programs to close a health inequity, and then subsequently scaling or refining those interventions over time. As I mentioned earlier, we'll ask for some additional narrative providing more context for how the ACO is achieving the indicated status and what progress it anticipates making in the coming 2 years. And as we note here, this year we will ask ACOs to provide responses across all of their component ACOs. So each component ACO will have a row in the template as you saw. Next slide, please. The second activity falls under the patient engagement opportunity area. As ACOs are working to develop interventions to improve health equity, this activity reflects the degree to which the patients that ACOs are trying to serve have a voice in that process. So here we're thinking specifically about folks impacted by a health inequity that the ACO is targeting. The status scale here reflects a modified version of a community engagement scale that's used by the Department of Public Health and others. Ascending that scale entails sharing information with these patients, then actively soliciting and incorporating feedback to inform program design, and finally offering patients the opportunity to help lead or guide development of interventions. We know this is a challenging area, but we think it's very important that ACOs explore ways to meaningfully engage patients in the design of interventions. There's no minimum standard for progress on the activity this year. This component of the health equity requirement is reporting only for now. But this is an area where we at the HBC are very interested in finding resources and support in the coming years to help ACOs build on their capabilities in this area. Next slide, please. The final activity pertains to the strategy opportunity area. This activity gauges whether ACOs are making organization-level commitments to health equity and whether they're starting to apply a health equity lens broadly to the work or the operations of the ACO. We will ask applicants to report on whether each component ACO has made any explicit commitments to advancing health equity in its strategic plans, whether it has set any goals in this area as an organization, and the degree to which ACOs are operationalizing or implementing any health equity components of strategic plans. Essentially, we're seeking to understand here the degree to which ACOs are applying a health equity lens to any of their activities and operations. Our intent here is to home in on actions and changes that ACOs are putting into practice. This activity could take a great many forms in practice, demonstrating leadership commitment, developing internal financial incentives like performance-based compensation or shared savings distribution methodologies that promote health equity, dedicating staffing, funding, or technology to health equity efforts, offering relevant staff and/or provider trainings, and/or improving hiring or retention practices to increase diverse representation in the ACO. This is an opportunity to showcase what ACOs are committing to and achieving at an organizational or strategic level. As with the patient engagement activity, there's no minimum standard for progress on this activity this year. This component of the health equity requirement is also reporting only at this time. Next slide, please. Okay, I'm going to turn it back over to Christy to walk through the upcoming certification timeline.
Thanks, Mike. So here's the timeline that we're working towards for the remainder of this year. Starting with May and June, where we are currently, we've released the platform user guide or the PUG that we've been mentioning. and as of today, reviewed our application requirements with you all in preparation of the upcoming application cycle in the fall. Headed into the rest of the summer in July and August, we'll be hosting optional office hours for 30 minutes every other week to answer any questions that you might have in anticipation of completing the application in the fall. As we mentioned, we'll follow up from this meeting with that meeting series and invite anyone to hop on to those sessions to ask questions. Though I will note, if you are unable to meet during that time that we said, we're also happy to find another time to meet with your team and answer any specific questions that you might have about your application. During this time frame, July, August, and we're headed into August, really, we'll open up the application portal and give you access to the intent to apply form, which ACOs are required to complete before they get access to the full application form. We'll make this available to you, and we'll ask that you do this no later than late August or early September. But we will follow up with more specific information on the intent to apply form and making that available as we get a bit closer towards August. Moving into September, we'll turn things over to you, and applicants will be working on completing their application for a submission deadline this year of October 2nd. And once all applications are submitted in October, we at the HBC will begin our review process and work to issue all final determinations to ACOs before the end of the calendar year. As promised, I did want to circle back to confidentiality for ACO certification materials. Now, as ACOs respond to the criteria in the application, and this is similar to previous years, it is important to understand the confidentiality protections that are in place. And for a little bit of background, in setting this policy, we sought to balance both the value of the market and having some transparency with real business confidentiality interests. So with that, there's a small set of data that we plan to publicly report on in an identifiable way that's listed here on the left-hand side of the slide in the blue box. And you can generally find those basic pieces of information about ACOs in the ACO profiles that the HBC periodically releases, and that we recently released an updated version that many of you had reviewed and is now available online. Beyond that information, for all other information that's submitted for certification, the HBC will keep that information confidential, and that's what's shown here within the box we'll keep that information confidential unless the ACO specifically consents to release of information. There's an opportunity in the application portal to offer that consent for responses to various questions on the application, and goes through each of the individual sections within the application, and an option to consent for a release of information. It's important to note here that the HBC does have authority to publicly report on information at an aggregate de-identified level. With that, I think we are ready to open it up to question and answer. And I know we had a couple things come through in the Q&A.
Actually, we don't have any active questions at the moment, Christy, but if folks have anything, now would be a great time to drop some questions in there and we can get you some answers. Maybe as folks are thinking, we can go to that next slide, Christy, and just do a plug for upcoming office hours on our website. I think folks know you can always reach us at this HBC certification mailbox. Any questions or communications can come through there. And we do encourage you to check out our website. This is where the PUG and any other resources relevant to this year's process will be. That's where this recording of the webinar will be. And also any outputs that we put out in the past, including the profiles that Christy mentioned and some recent program strategy summaries that we've published. And as I mentioned at the outset, we're going to start office hours in a few weeks. We'll send out a calendar invitation. And as I said, those are totally voluntary, but we encourage you to drop by, ask any questions. and talk about the application. Okay, we've got a question about the new health equity requirement template. So there is a drop-down menu, and the question is, will there need to be any documentation uploaded as part of that? And the answer is no additional documentation. We're looking for more of a narrative description in those columns next to the drop-down menu. So that's where we'd ask for a little bit of explanation as to why you chose that particular status, what that means in the context of your organization. But at this time, we're not requiring any additional documentation. Question about the timing on access to the application. So late August, early September would be the latest we would open it up. I think in the past, we've been constrained by the actual IT process of building updates to the platform. And I think we have less constraint around that this year. So it may be earlier in August that we can open that up. Folks can start filling out their intent to apply forms and get started with the process. But we'll have more updates via email about that. Any other final questions before we adjourn? Question about the Excel template. So yes, those are all, except for the health equity requirement template, those are all currently available on the ACO certification website, and we can shoot around a link to that again. The health equity requirement template, since we're customizing it for each applicant, we'll send that out as an email communication to you all pretty soon. But yeah, those will all be available well in advance of the application period, formally kicking off. Okay, I think we can wrap up, folks, but thanks for joining us today. It's always great to see all of you, and you can always reach us via email or drop by office hours for any additional questions that come up as you're starting to think about the process. But we're looking forward to working with you all. Thanks very much.